Muchas gracias. Thank you. Great. Thank you. Yes, good. Thank you. If you can a little bit lower, can we dim it a little bit? Oh, well, it's okay. Let's leave it like that. Thank you. Okay. Well, as a continuity of the talk I gave yesterday about restoring vision in patients and trying to create a nice impact for the quality of vision and life of the people we see with corneal diseases. Today, hold on, let's. Okay, I'd like to speak today of another great chapter. Instead of seeing healthy patients with corneal ectasia, that they are disabilitated because of this abnormal curvature, and that we need really to treat them. And the aim of the treatment initially is to restore the vision and make them function again in their daily life and activities. This topic actually it's firstly to save people's eyes. So we're gonna talk about two or three diseases that they are eye-threatening conditions that the people can lose their eye. And after treating that, how do we rehabilitate them so they can, again, have a normal life? Okay, so there's two basic conditions. This what it's called a PUK. The PUK, it's a peripheral ulcerative keratitis, Murin's ulcer, and scleral melts that we see in people post-op of different ocular surface diseases. These three conditions are eye-threatening conditions. So we need to evaluate really well what's the treatment, and we're going to talk through this speech, the medical treatment, the surgical treatment, and the vision restoration. So initially, as we know, Murin's ulcer, compared to the PUK group, Murin's ulcer is a rapidly progressive, painful ulcerative keratitis. This initially affects the peripheral cornea and may spread circumferentially and then centrally. So the problem of Murin ulcer and other degenerations of the cornea, the circumferential cornea, is that they start thinning because of some immune response that it's a bit unknown at the moment. Most of the etiology, we know it's immune, but all the exact process from beginning to end of it, we really don't know. So what happens is this thinning on the periphery of the cornea. Of course, this is kind of an advanced case, but once it starts, you really can't tell. It's just a very mild gap that is happening at the end of the cornea on the border with the limbus. So that creates the cornea tissue and the cornea collagen fibers to soften on the periphery, and then this creates an alteration of the curvature of the cornea with some visual deficiency of the patient, and this astigmatism will create a drop in vision over the time. If we let this melting of the cornea conduce, then it will continue around the eyeball, as we're going to see some examples on the next slide. On the other part, we have PUK, which it's the other side. It's a condition, we know the cause, which is very symptomatic. It's painful, okay, and usually it's caused from an external and an exogenous pathogen like bacteria, virus, fungi. Okay, a lot of patients we see, they have an immune complex. So either they have a systemic condition, or it's also based with skin conditions that will make some kind of disorder in the immune system that it will create the same effect. It will start having a corneal melt on the side of the cornea. Usually, it's not as severe as Murin. PUK, it's painful, and that will give us the notice and the patient the notice to go and visit the doctor, and then we can initiate treatment. But some of the murine patients, just over time, they melt, and when they reach the office of the doctor, then the disease will be quite spread. This is some of examples on comparing murine ulcers. So we see the peripheral melt. It can be really, really bad all over around. Okay, it's this over here. Okay, so this thinning, which gives it's a bulging of the anterior cornea. So it will create an effect of myopia and very irregular astigmatism with a very serious dropping of your vision. PUK, it's very important to make the difference in the diagnosis, and basically it's clinically. Some of the photographs, even you can see it's quite similar. So if we mix this all around, you really need to see the patient and ask the patient how they all started, and try to fix up the ideas in the head, because by images, like I said, if we mix them together, we don't really know which could be one, except for this one probably. It's very mild. But murines can start like this. So this immune complexes that happens in PUK, it's a whole drop of all the immune system on the conjunctiva. The conjunctiva, it's in contact through the limbus with the cornea. So it's a difference between the center part of the cornea and the extreme part of the cornea in continuations with the limbus. So the immune system on the center of the cornea, like it's an avascular structure, then it will really just have some migration of white blood cells when you have inflammation. But when you have a contact with the conjunctiva, then the red blood cells with all the carriers through the blood vessels will give an extreme inflammation that could make corneal melt or the limbus melt. Okay, so we can really see eye-threatening conditions in both diseases. Murine goes like this, and PUK looks like this. So it's very similar, just that probably murine goes a little bit more to the edge than PUK, but they both can give complete opening on the eye, and of course you can have an infection, you can have an endophthalmitis and lose the eye. The chances of losing your eye in both conditions, if it's not treated, it's extremely high. Once the eye it's bulged, like in these cases, and once there's contact with the external world, then if you do have a bacteria that goes in and you create an endophthalmitis, treatment is especially hard, because you have not only the inflammatory condition to deal with, but the infection. So once we've seen infections in the eye, like endophthalmitis, we know that the chances of the patient to lose their eye is very high. And if treating only with antibiotics, it's very hard. Now we need to plus the anti-inflammatory drugs. So for this, sometimes you need a lot of steroids, and it's a juggling between steroids or not. Some people are benefited with the use of steroids, and they really improve until you stable the eye, but some other patients, you use steroids and they go worse. So it's patients that we really need to see during the clinic very, very regularly to see how they develop. So it's all incumbent in three ways as I see it. Firstly, you need to save the eye. Then you need to keep the eye safe, and then you need to restore the vision. So saving the eye, basically when you get a patient in your clinic that has a hole in it, you really need to restore that hole. And you can do it any way or in any condition you can have. If you do have an eye bank in your hospital, or you do have corneal tissue to repair, some of us prefer to go straight and do a patch. And you can do same as I mentioned in that talk yesterday, you can do a corneal transplant. It can be either full thickness if there's a hole there, or you can try to do an inlay and dissection, so you can keep on having a lamellar transplant and not a penetrating keratoplasty to avoid a secondary immune reaction. So in some of the hospitals, especially in developing countries, you might not have corneal tissue available. So, but you do have glue. So you can have very elegant tissue, fiber tissue, or what the plastic surgeons use to paste the skin, or you can have just commercial glue to do it. So you can just patch it there with glue, and you put a soft contact lens on top, and you just hold it while you ask the eye bank to send some tissue. Secondary, you need to keep it safe. So two things are going to happen. You're going to graft the patient, and you're going to keep it with systemic medications and drops. And this needs to be in the correct time. So once you repair the melt and you repair the eyeball, it's again a sealed camera. Then you need to treat very aggressively with anti-inflammatory and antibiotic drops and systemic medications. Once it's safe for some time and it's all right, then you can restore your vision. So a lot of these patients, what happens is that with let's move forward so I can show you this multi-lamellar keratoplasty. So we do have a corneal melt on the side and that we need to restore. This is a very thin tissue with a lot of inflammation around. So we need to pull the conjunctiva back, and we need to restore that eye. Okay, so which is going to be something like this. I'll show you how we do it. So once we repair it, I'll show you the steps in a minute. Okay, then we can, over that, if there's a lot of distortion of the center of the cornea, or some patients that leave some scar behind, or really the corneal repair has to go all the way to the center of the cornea, your suture will get in the way. So it's just going to be in the pupil axis, and you will have an enormous distortion of the vision. So you need to repair that. So in a second procedure, you can go to the lamellar keratoplasty or a penetrating keratoplasty in the center. So, and you will remove part of the previous graft that you put. So at the end of the day, you will have a normal, healthy, clear cornea in the center for the patient's restoration of sight. Okay. How do you do it? Okay, so what we do is we remove the unhealthy tissue. Okay, this patient itself has the form, the shape of a banana, so we will call this a banana lamellar graft from now on. Okay, so we remove all the unhealthy tissue. We need to do all the marking first of the center of the cornea. We put the markers with a marker pen. We use different diameters of tree fines and calipers to make really the exact shape we do want to do. So after this, we go to the donor, so the donor tissue. So we'll fix it like this. This is like a Mickey Mouse shape we have here. So Mickey is going to help us today. So again, we do all the marking with different trefines and calipers, and we will remove this banana shape graft. After that, we make the cuts and we do a dissection. It's going to be a lamellar dissection, okay? And then we put it on top of the eye. We leave an extra tissue on the sides. We know the marking, okay? But we do leave an extra tissue just in case we need. So we start suturing that. We need to be very careful with the sutures on the center. Firstly, because the cornea is thinner on the center, and the other one is that we'll create an enormous astigmatism that you need to deal with that afterwards. So at the end of this first surgery, it will look like this. So this is a lamellar patch graft. Okay. Then you put again the conjunctiva. You can put it again here. Okay. Finally, after probably 3 or 4 months after that surgery, everything is stable. You have a patient in very low dose of steroids and anti-inflammatory drops. Then you are able to restore the central vision. So for that, you can do a lamellar keratoplasty also, or a PK. That sometimes it's very thin. You need to do a PK, but we really try, as we explained yesterday, that we need to do a lamellar keratoplasty. So we do it on the center. So dealing with the sutures around the eye, it's much easier than to have center sutures. So this patient is being able to restore quality and quantity of vision. If we do want to push it a little bit more to have a final uncorrected visual acuity very useful, then you can do a LASIK on top of this. Okay. Now, I prefer in these patients to do LASIK and not PRK or LASIK, because you do have an immune response very regular, because the base disease, it's murines. All right, so you don't want to play around with the immune system. LASIK is a very noble and very non-inflammatory surgery that can help you to restore the patient's vision. Okay, to finalize, I'd like to see something that we do. We do see patients in the clinic that has conjunctival degeneration such as this, and when they have surgery, we know that surgery for this has many ways to do it. You can have bare sclera, you can have a conjunctival graft, you can have put mitomycin, you can put beta radiation. There's a lot of treatments for this. So you see from time to time in your clinic patients that come in and say, well, doctor, a few years ago I had the surgery of the conjunctiva, everything went well, but there's like a nevus coming out of my eye. It's something I didn't have, and something's like a little thing coming there. It has been for a few months, but it's growing. And then I saw my friend, or the friend of my mother, and then she said that, well, if you have a nevus that it's changing of color or shape, you should go and have it excised. So people come in the clinic saying they have a nevus. And what you really have is a scleral melt, okay? And what you're seeing on the bottom is a choroid and the retina behind. So these scleral melts are well known that it's because of the beta radiation and the mitomycin C. So please don't use mitomycin C or beta radiations to remove the pterygium or pingueculas, because between 15 or 30 years afterwards, you can have a really bad scleral melt. The best way to remove pterygium these days, it's removing unhealthy tissue and putting a conjunctival graft. So when you have a patient like this, then you need to deal with it, because if not, it will get perforated. So you go into surgery, you remove the conjunctiva round. There's the bulge of the choroid with some episclera fibers on top that if you want to press it down with heat, you can burn a little bit the episcleral fibers, and this will condense the tissue down in shape. Then you can, sorry for the photo, it's a little bit blurry. So once it's okay, you take a dermal punch, a dermatological punch of between 3 and 4 mm, and you're going to press around the sclera, and you're going to make a healthy hole. So you make your borders very healthy, and then you take either cornea or scleral donor, and you're going to patch it there. So it's going to end up like a little nice sun there. Then you don't want to leave the bare sclera again to produce any further melting. So you cover it with conjunctiva. So you do either a conjunctival graft or you just make a conjunctival rotation. Okay, so in conclusion, PUK and murine are very threatening eye conditions. The surgical repair and the pathology itself leave behind corneal astigmatism and scarring. Central corneal transplant is an effective way to remove the scarring and irregularity of the vision. So we're able to combine two types of corneal transplantation. Okay, one is to save the eye, and the other one is to restore the vision. If from there on we want to rehabilitate the patient more, we can do laser surgery on top to make as close as 20/20 vision for them. Thank you very much.